one says 10 minutes. Maybe this is before. No, we're ready for this. The first thing. Is this Gabby? Do you have this as the speaker here? Oh, can we? Thank you. We just changed it to 12 and 8. 12, well, I think it just has 20. Whatever.
Good morning. So I'm Stephanie Fuller from the Children's Hospital of Philadelphia. I'm joined today by my co-moderator, Christine Gulasarian from Medical City in Dallas. We put together a session this morning called SOS, and the idea behind this session is essentially to present multiple case situations that we often encounter as complex case situations. And many of us, whether these are either complications of surgery or inadvertent consequences of surgery, are often challenging to deal with. The structure is to have this be a very free-flowing format with about 12 minutes per presentation and about 8 minutes for discussion after each presentation. So I greatly appreciate all the speakers who have taken on these very challenging topics. Our first speaker is going to be Glenn Pelletier. He is here from DuPont Hospital in Delaware, and welcome, Glenn.
Could I have the slides, please?
Thanks for following.
Sure.
This is these are the slides under
I think it's still under Christian's name.
Maybe while we're loading up the slides, can you please raise your hand if you've never ever been in a tough situation in the OR? Okay, just one. Okay, yeah, tough situation on the podium here too. There we go. Okay, so right. Say politics aside. This is just a clinical tough situation. This has nothing to do with the administrations of your respective institutions.
Okay. All right. Well, good morning, everyone. I appreciate the opportunity to open this forum today, and on behalf of Christian, who could not be here this morning, I will begin with the topic of neo-aortic valve regurgitation after a Norwood operation. How do I advance? Does this advance?
Could you please advance the slide? Could you please advance the slide?
I have no disclosures. Next slide, please. By way of review, which is probably very familiar to everyone in this room, the principles of the Norwood operation are to achieve unobstructed systemic outflow from the single ventricle, unobstructed pulmonary venous return, and a controlled source of pulmonary blood flow. And if all of those things are accomplished, there are still problems that can arise, and I will speak about that one being neo-aortic valve insufficiency. We'll begin that with a case presentation that we dealt with at our institution. Next slide, please. Sure. So in fetal consultation, this mother who had multiple medical problems had a fetus diagnosed at 28 weeks of gestation with double inlet left ventricle, LDGA, a small outflow chamber, however, unrestricted bulboventricular foramen, aortic valve hypoplasia, arch hypoplasia, and coarctation. There was 2-to-1 heart block in utero with intermittent 1-to-1 conduction. Next slide, please. Thanks. So the baby was born at 37 weeks gestation via C-section due to concerns about the heart tones, which may have been the arrhythmia. She was born at 3.6 kilos with good Apgars. Prostaglandin infusion was initiated. The conduction remained intermittently 1-to-1, and the echocardiogram confirmed the prenatal anatomy. There was good ventricular function. The branch pulmonary arteries are of good size. The dysplastic pulmonary valve measured 8 millimeters and had mild to moderate regurgitation. And the aortic arch and isthmus were small with bidirectional flow at the ductus and a non-restrictive atrial communication. So the first decision we encountered was what to do, and these were the options that we considered listing for transplant, a hybrid palliation, hybrid plus a pacemaker, or a Norwood operation. On day of life 7, child underwent a Norwood operation with a 3.5 millimeter right modified bilactasic shunt and the usual reconstruction of the aortic outflow. After the surgery was complete, in the process of reperfusion and rewarming, hypotension was noted with a perfusion pressure of 20 millimeters of mercury, despite the shunt being closed and a cardiopulmonary bypass flow of 125 mLs per kilo per minute. In troubleshooting this problem, the venous cannula was advanced across the tricuspid valve to decompress the heart. That had no effect on the blood pressure. However, occluding the ascending aorta just proximal to the aortic cannula led to a rise in the blood pressure, suggesting that aortic insufficiency was a problem. There was also differential perfusion of the heart, that being that parts of the heart were pink and seemed to be well perfused, and other parts dusky, and it was accompanied by poor perfusion and complete heart block. Unfortunately, this clip doesn't play, but the heart's very distended. There was very poor contractility, and spontaneous contrast within the ventricle was noted. So decision 2 came up, and these were the choices that we entertained, either transitioning to ECMO, coronary revascularization, although it wasn't clear what that revascularization would be, takedown of the BT shunt and placement of the RV to PA conduit, revise the proximal amalgamation, or insert a Berlin heart. So given the findings after the first part of the operation, takedown of the proximal amalgamation was performed. It was discovered that there was an anomalous aortic origin of the left coronary artery behind the rightward commissure. And so that native ascending aorta was moved to reach the underside of the aortic arch by inserting a 4 millimeter PTFE tube as an interposition graft. The neo-aortic valve, the pulmonary valve, was inspected and there was no injury noted, and that part of the amalgamation was repaired. Again, coming off bypass, the heart was no different, and there was a severe amount of aortic regurgitation present. So at that point, the decision was to replace the neo-aortic valve with an aortic homograft. and insert pacing wires and transition to ECMO. On postoperative day 2, myocardial function had improved to near normal. The aortic insufficiency was 0, and the patient was making progress such that by day 4, she was able to be separated from ECMO. And by day 11, the endotracheal tube was removed, hemodynamics were good, and she was remained paced in a AV sequential manner. The BNP was 400 at that point. These circumstances continued for approximately 8 weeks. She did reasonably well, at which point the pulmonary homograft failed and regurgitation returned. The child needed to be reintubated at about 10 weeks after surgery and was placed on the transplant list. Unfortunately, did not receive an organ, and at 4 months of age succumbed to a multi-organ failure. So the manifestations of neo-AI that we observed and that are relevant are that the heart is distended and with a poor perfusion pressure despite being on cardiopulmonary bypass, which leads to decreased function, high peak pressures, pulmonary edema, hemorrhage, etc. There may be ischemic changes, either visible or electrocardiographic, and ventricular fibrillation may ensue. Some of the potential causes that we explored and that need consideration when this happens are any distortions of the reconstructed outflow, either distortion from the tourniquet position of the aortic cannula, arch obstruction distally, distortion of the amalgamation, or the nearby adventitial tissue that could potentially tether that area. An injury from the neo-aortic valve at the time of initial cannulation of the main pulmonary artery, and of course myocardial ischemia. So the challenges involved in this situation with the neo-aortic insufficiency include the obligatory volume burden with norwood physiology, the delicate and precarious, sometimes precarious coronary perfusion, which can be exacerbated by a systemic to pulmonary shunt, decreased coronary reserve with subsequent ischemia and poor function. It's also notable to remember, although that there are factors involved in impairment of oxygen delivery to the myocardium, there are also increased demands placed on that myocardium, such that when there is a parallel circulation with a QPQS ratio that ranges from, say, 0.5 to 1, that workload on the heart can be 1.5 to 2 times or even greater. So there's a clear imbalance between supply and demand on this myocardium. And as has been shown in previous studies, the myocardial blood flow in hypoplasts is considerably less, both at rest and when challenged with adenosine compared to other congenital heart defects. Now, the timing of intervention really relates to when you recognize the AI and how severe it is. Notable when ECMO support is being considered in a situation like this, as was shown in the SVR trial, ECMO or the need for ECMO or CPR or both has a profound impact on freedom from death and transplantation, such that if someone needs to place the patient on ECMO in the early intraoperative or postoperative phase, that understanding what the problem is necessitating that support is important, and that neo-AI is not one of those problems, because to have efficient ECMO support, obviously a competent semilunar valve is important. In addition to neo-aortic semilunar valve regurgitation, there's native aortic valve regurgitation. This has been addressed by this group in Cincinnati, Riggs et al., in their effort to use this left ventricular exclusion technique, has oversewn the native aortic valve, leaving a small fenestration or hole to allow for washing across the valve, but it was a way to deal with that type of aortic insufficiency. This report showed a device intervention using an Amplatzer duct occluder and a neonate as well for a similar circumstance. Later presentations are a little bit more insidious and perhaps related to the magnitude of the aortic insufficiency and can be better tolerated sometimes. However, coronary steal, dysrhythmias, heart failure may all be presentations, and the treatment surgically may be challenging due to the small nature of the annulus. Transcatheter device occlusion using a vascular plug has been performed for native aortic valve insufficiency. And this one was placed in the left ventricular outflow tract for severe regurgitation and actually shunting across the VSD at the same time. This was successful. And up to 3 years of follow-up, there were no AV valve conduction abnormalities or recurrence of the insufficiency. This report dealt with, again, an older patient after the Fontan completion with progressive AI and the delivery of a Melody valve in the neo-aortic valve position with a good result and follow-up of 2 months. These anatomic relationships always have to be at the forefront of any decision about what to do, either surgically or through an interventional procedure to mitigate against heart block, coronary obstruction, thrombus formation, and the like. And as has been shown in patients with HLHS that have had an aortic operation, there is dilatation of the AV valve, of the aortic valve, the neo-aortic valve, the sinuses and the ascending aorta, creating aortic insufficiency, and that valve-sparing aortic root replacement can be an effective treatment for that. So in summary, significant neo-aortic valve regurgitation is a rare but serious issue. The acute presentation during the time of the Norwood can be extremely destabilizing, and early and prompt recognition of the cause is obviously vitally important. Avoiding myocardial distension and achieving a reliable systemic perfusion are the goals. And in severe cases, consideration for a homograft replacement of the neo-aortic valve is feasible, as was demonstrated by this case. If ECMO support is needed, a semilunar valve should be competent, then transplantation may be a consideration. Native aortic valve regurgitation likewise can be addressed, as was shown through the left ventricular exclusion technique. Lesser magnitude and later presentations may occur. Coronary steal and heart failure, however, may ensue later on. And either surgical patch closure of the aortic valve or interventional techniques may be used for this problem. Thank you for your attention.
Glenn, thank you so much. We're going to open up the floor to some questions, and certainly we'd like to hear some experience of others in the audience who have dealt with a similar problem. This is, of course, a devastating issue coming off bypass after Norwood. Glenn, I appreciate you pinch hitting for Christian, who was unable to make it today. I believe the case report that discusses use of a Melody valve was actually after the use of a bioprosthetic valve. Then that bioprosthetic valve became stenotic within about 1 year, hence the Melody valve used. But I'm curious if anybody has any experience with surgically placing a percutaneous valve in the aortic position in a neonate. There's no takers, huh? I think we're fairly limited in terms of what our options are, other than potentially using an aortic homograft in that case.
Mm-hmm.
Maybe just one quick follow-up question. In the patient with a bicuspid pulmonary valve, starting off with some pulmonary insufficiency, any experience either with you or anybody else in the audience with some techniques up front to help prevent neo-aortic regurgitation?
I think the most common reason for aortic, neo-aortic incompetence of the pulmonary valve is a long or a large arch valve.
Can you hold on one? Can we have a microphone, please? Hani, if you don't mind starting over.
Yeah, so in my view, the most common reason for neo-aortic incompetence is did not exist before surgery is the patch size. Most of the time, the distance between the distal pulmonary artery and the descending aorta is very small, although when we are dissected, it actually looks big and you put a big patch. That's why that part has to be shaped like a crescent. And you pull up the posterior commissure. And even if you get something of that sort, I don't know if you've tried just a application suture of of the aortic patch. And if you were to, and sometimes that's just sorts it out as you come off bypass. You would see it immediately when you take the clamp because the heart fills up immediately. You recognize that. And you put a application, usually the arch is huge. So it's not a deal with narrowing the arch.
That's a very good point. We obviously did look at the arch very carefully to see if that was a problem, and did not appear to be based upon the contour of the patch and how it came together. So, but that is a very valid point.
And it's a simple maneuver. And if you were, you could just redo the amalgamation again and cut majority of that patch posteriorly, and it pulls up the neopulmonary artery.
Mm-hmm.
Honey, I think you bring up a good point where I worry also about potentially any eccentric cut into the pulmonary artery at the level of the sinotubular junction that potentially can cause distortion of the valve because of an uneven sewing edge that due to kind of how that incision is made across that neo-aortic root.
Chris, Dr. Baer?
Great. I agree completely with Hani and Stephanie, your comments about the amalgamation and the way you bring the patch up. And so I personally wouldn't plicate anything. I'd take it down and redo it because it often distorts or rotates that commissure of the valve. But I think importantly, the question is if you have some regurgitation before your arch reconstruction, that's really, I think, the question. What are some techniques, or how can you avoid having that regurgitation? And I think in our experience, what you can sometimes do is do a subcommissural plication. In fact, a lot of times in a Ross or a neonatal Ross, you can plicate in that non-coronary subcommissural area, and it actually brings that valve together nicely. And we've done that a number of times if you have this regurgitation pre. Just by bringing the commissures up, it allows the valve to come together nicely. So I think the subcommissural plication is very helpful in these situations. And you can also do that sometimes at the second stage if you have some neo-aortic regurgitation. You can even do it from the ventricle if you're taking your RV to PA conduit down. It's a pretty simple figure of 8 suture.
Thanks, Chris. I think I've tried the usual commissural sort of plication. That seems to work out okay too. So I guess primary prevention, but if you do get into a tough situation, these are some good ways, I think, to get out. In the interest of time, we're going to move on to our next topic. Thank you very much, Glenn. That was excellent. I'd like to ask Dr. Ming Si to join us at the podium. He's going to be talking about severe AV valve regurgitation following AV canal repair. And I think many of us in this room have just heard Dr. Jenna Hirsch talk about some AV valve repair techniques in the single ventricle, but here we're jumping into the 2 ventricles. So thank you, Ming.
Yep. All right. Well, I'd like to thank the organizers, Christine and Stephanie, for inviting me to talk to you about an important issue, which is severe atrioventricular valve regurgitation after CAVSD repair. I have no disclosures. In the matter of interest of time, I'm going to skip over a couple slides. So, surgical repair of complete atrioventricular septal defect. There are the 2 most common methods of repair that used currently are the 2 or double patch method and the modified single patch method. The 2 patch method, as you know, there are separate patches to close the VSD and ASD components, and the modified single patch kind of plaster down the AV valve onto the crest of the septum. However, both approaches require closure of the left AV valve zone of apposition, also known as the cleft, provided that there's an adequate mural leaflet. If there's an inadequate mural leaflet, some of that cleft must be left open, otherwise you have left AV valve stenosis. I'm not going to talk about left AV valve stenosis. My talk is mostly focused on regurgitation. So over the past few decades, the results of complete atrioventricular canal repair have been summarized. Recently, there have been some nice studies that have been published. Most recently out of the Australian group, there's a large study published in JTCVS of over 800 patients. And in that study, the majority of patients were treated with a two-patch approach. There was over a 90% survival at 10 years, but there was about a 15% reoperation rate at 10 years, and over half of those were related to left atrial ventricular valve regurgitation. The other studies that were published recently I listed here had very similar results. Good survival at 10 years, but a significant reoperation rate of about 7 to 10%, and most of those, or over half of those, related to left AV valve regurgitation. So what are the risk factors for left-sided AV valve regurgitation, and what are its implications? Well, in one of these studies, one of the risk factors was a second bypass run during the initial repair or a preoperative moderate or worse atrioventricular valve regurgitation. That's a little bit controversial because other studies have not shown preoperative AV valve regurgitation to be a risk factor. And second bypass run is not very informative. A small study by Beauvais and colleagues showed that the majority of failure for the left AV valve was secondary to some technical reasons, such as cleft suture dehiscence and incomplete cleft closure. But what about the mechanisms that lead to moderate or more regurgitation immediately post-repair or during repair? Well, a potential mechanism of this atrial ventricular valve regurgitation was studied in this nice paper by the Boston group. And essentially, they looked at about 100 patients and studied their echocardiograms and main measurements. And what they found was that the shape of the left atrioventricular valve becomes more circular as opposed to elliptical. And this increases the length of the septal to lateral wall distance, and in essence, pulls the leaflets away from each other. So for left atrioventricular valve regurgitation, you can notice this postoperatively, intraoperatively, but what are the indications for reintervention? Well, I think greater than mild left AV valve regurgitation is a major reason for reoperation and has significant patient outcomes, as I showed you in the previous slides. Establishing competency during the primary repair should be the first priority. And detecting this intraoperatively is therefore very important. So saline testing is important, is our way of judging our repair, and must be done so that you have some pressurization of the left ventricle and to see if there's any regurgitation from the repair. For patients who are remote from their operation and come back, the indications may be a little bit different. Certainly, symptomatic patients would require reoperation, but asymptomatic patients should also be considered for reoperation if they have some left ventricular dysfunction or progressive dilation. So what are the treatment modalities for left AV valve regurgitation? Well, there's repair and replacement. Obviously, we try to repair these valves in infants and children, as well as adults. But sometimes you have to do replacement. Most of the remaining of my talk will focus on repair techniques, but I will have a few slides on replacement as well. So repair of the regurgitant left AV valve. Repair always begins with careful analysis. You need detailed preoperative studies to define the anatomy and morphology of the valve throughout the cardiac cycle. Intraoperatively, saline testing is important, and careful observation as to where these regurgitation jets are occurring and what are happening to the leaflets. 2D and 3D echocardiogram for those patients that are coming back postoperatively is also very important. So I think functional, while you're doing the saline testing and echocardiogram, functional analysis of the regurgitant left AV valve must be done before you make any plan of addressing the regurgitation. So I like using Carpentier's functional classification. It provides a template, a standardized template to analyze these leaky valves. There are 3 types. There's type 1, type 2, type 3, and I'll go over these in detail. So type 1, you have normal leaflet motion. Leaflets have normal mobility but don't coact against each other, and that's because of annular dilation or regurgitation through a residual cleft or perforation. So in our patients, it's mostly because of annular dilation and incomplete cleft closure. So to address annular dilation, you use annuloplasty, and there are a number of annuloplasty techniques described in Carpentier's text. But I think most relevant for us is the mattress, pledgeted mattress sutures along the annulus, or even more aggressive is the K-Reed type of annuloplasty, where you can downsize the annulus more effectively. So closure of the apposition. So if you notice that on echocardiogram, you have to place additional simple stitches along this remnant cleft. If the papillary muscle insertion is also very broad, you can close that area as well and create additional coaptation zone. So type 2 is not as common, so that's leaflet prolapse. Leaflet that has excessive mobility because of excessive length or leaflet length, chordal apparatus length. And the repair strategy, well, I should also mention, during primary repair, if this occurs, it may be from accidental rupture or tear of a cord. So if you notice that, and then the repair strategy is to place an artificial cord to restore normal mobility. Fortunately, we don't have to do this very often. There isn't much experience published in the literature. There is one study from Japan that shows, from Oda and colleagues, it's a 17-year experience with these EPTFE cords in infants and children. And these patients, where they had over 69 patients, there were only 2 patients that underwent AVSD repair, so not a huge experience. But this is how they place their artificial cords. They place it through the leading edge of the leaflet and come down through a pledget and through the papillary muscle through another pledget, and then adjust for the length and tie down that suture. The durability actually seems to be very good, suggesting that even though these cords don't grow, perhaps the papillary muscle or the leaflet it's connected to provide some growth. Another potential technique for prolapse or localized prolapse leaflet is this edge-to-edge technique, Alfieri stitch. We tend to avoid this because when you place this stitch here, it shows a normal mitral valve. When you place it in the left atrioventricular valve of an AVSD patient, the orifice is not as large, and you can certainly create stenosis with that. However, I think this is something to keep in your back pocket and use this during salvage situations. So type 3 is a restricted leaflet motion, where one or more leaflets has restricted motion and does not reach the other to coapt. So during primary repair of complete atrioventricular septal defect, this is primarily due to deficient anterior leaflet length. And going back to that study by the Boston group, showing that dimension between the septum and that lateral wall increases. So you really need a lot of length to that anterior leaflet to meet the mural leaflet. So the repair strategy here is leaflet augmentation. One thing, though, is to try to prevent that short leaflet from occurring. So I think it's key when you're placing, during the repair of the canal, that you avoid placing these sutures certainly on the left-sided leaflet, thereby shortening the length. If anything, place it a little bit on the right side. However, you do that and you still have a short leaflet, you have to augment the anterior leaflet. And this is something that was described over 10 years ago by the Toronto group. Here in their figure, they showed very shortened anterior leaflet and a very generous incision and patch to augment this leaflet. Certainly, usually we have, it's just very localized in the central region, and you could be more conservative in this incision and the patch you place. There are other methods described to augment the anterior leaflet. Here's one method where you use a patch, to augment the anterior leaflet as well as connect to the papillary muscle. You know, these methods I'm not as enthusiastic because there's patch material at the leading edge, the coaptation zone of the leaflet, and that will definitely fail. So I more favor patching the base of the leaflet and leaving the native tissue to coapt and provide growth potential. So I came across an interesting paper by Dr. Najim, published over a decade ago, of routine leaflet augmentation during repair of the left AV valve. And so this involves placing this pericardial patch that functions both as the VSD patch as well as augmenting this left atrioventricular valve, thereby increasing its height or length, and then reattaching the right AV valve. In his experience, he had 100 patients, age a little older at 11 months, mean follow-up 45 months, 2% mortality in this follow-up period, and 4% reoperation. Another interesting technique is this central patch canal repair technique. And this is first described by Douglas and Doshi in 2014. I think Dr. Douglas updated this experience on CTSNet and provided a nice video for those of you who are interested. And in this technique, during the repair of the canal, what you do is you mark the apposition zones and then make an incision over the central portion of the common leaflet, place your VSD mattress sutures, the crest of the septum, and then you start sewing in this patch, this pericardial patch, to augment this central leaflet. First sew it on the left side, and then you pass these VSD sutures through this patch, and then complete this patch on the right side, place additional VSD mattress sutures inferiorly as needed, and then complete the ASD repair. I mean, in essence, it's almost like a modified single patch where you push the AV valve down to the septum, and so you have both larger left-sided and right-sided leaflets. So on CTSNet, he has done 23 patients, claims that he's done 23 patients over 6 years, and has had no mortality, no need for reoperation. So if all the repair efforts fail, then you start looking at replacement. Okay. So for repairs, just to summarize, in the interest of time, there's no good repair options for very small patients, as you all know. Some have described these contegra conduits turning them upside down, pulmonary homografts turning them upside down, pulmonary autografts turning them upside down as a mitral valve. But in all of these, actually there's one more, Melody valves by Dr. Amani's group. But all of these techniques carry significant morbidity and mortality. So avoiding them in the first place is paramount. So in summary, standard repair of complete canal provides reasonable results with good survival, but about a 7 to 10% reoperation rate for left AV valve regurgitation at 10 years. The left AV valve may acquire unfavorable geometric changes which predispose to regurgitation. Functional analysis of left AV valve regurgitation is necessary to select the appropriate repair techniques. And replacement in infants with non-standard options are suboptimal and thus result in significant mortality and morbidity. Therefore, the surgeon must be aware of all the various AV valve repair techniques to avoid this situation of replacement. I'm happy to take any questions.
Thank you very much. See, Doctor, yep, go for it.
Thank you. I think the technique that I still use the same technique, and probably we have more than 250 cases with that. Long-term results are awesome, really. This is first autologous pericardium, so it's not treated even, but it's sized appropriately and to make sure that it's not floppy or excessive, that it doesn't dilate. But I wanted to mention something about the left AV valve technique repairs in late AV canals. Is a completely different setup that comparing it to the adults. The adults have the anterior leaflet attached to 1/3 of the annulus and it covers 2/3 of the surface. The other way around for the posterior, while in left AV valves is 2/3 of the annulus and 2/3 of the surface area by the anterior leaflet. And the posterior leaflet, you do not want to do any annuloplasty posteriorly because you'll abolish totally the mural leaflet function. It'll get fixed. And what we do is actually we do a reverse annuloplasty. So we actually put the annuloplasty the other way around to pull out the anterior leaflet attachment. And what is the anterior leaflet attachment, which is a combination of the bridging leaflets. So you actually pull up, so you have a lower attachment of the anterior leaflet, you cover more of the surface area because the surface area is still the same, and you pull up the posterior or the mural leaflet up. So the techniques is not transposable between the adults and the pediatrics in terms of the techniques of a mitral. It's not anymore a mitral valve, and it will never have the same mitral valve techniques. The other thing is that you haven't mentioned is work at the papillary muscles. There's a lot can be done with the papillary muscles because they're typically either close to each other, they're attached to the free wall of the ventricle. These can be all freed up. This will allow leaflet mobility and allow better coaptation.
Thank you.
Thanks, Hani. One more.
Apropos of the last set of comments about taking down the neo-aortic root, I often tell the trainees that in general, when you're running into problems in the operating room, the correct answer is almost always the most painful one. And AV canals are definitely the most origami that we do, where you can't test it until it's all done. And I do think that when you're caught with pretty significant AV valve regurgitation after your repair, you have to give a thought to whether you should just take the whole damn thing down, because it may be something that starts with the original sin of the size of the patch or something like that. And it's always very tempting to want to say, like, I'll just close this cleft and I'll do a little nip and tuck and I'll make it better. But sometimes you just have to take a couple steps back.
Good point, thank you.
Thanks. And one more comment too. I think all of us have experienced the non-Downs canals tend to have deficient mural leaflet, and I think your comment about sort of cheating to use a little bit of the right-sided super bridging leaflet and sort of bring it over is helpful, but be careful because it may not be enough, and that's where the augmentation comes in. And then one other small point, I don't know if anyone else uses this technique, but in testing the valve, every third or fourth test, I use cardioplegia because one thing you want to make sure is that you have adequate myocardial protection, and you may wash out your cardioplegia, so just a little trick.
Good.
Thank you so much.
We're going to move on to Dr. David Overman. He's here from Children's Minnesota to discuss dysplastic tricuspid valve with severe TR in the presence of pulmonary atresia in the neonate.
Good morning, everybody. Thanks to the organizing committee and to you, Stephanie and Chris, for the invitation. I'm not sure if it might be some form of punishment that I don't recognize, but at any rate, hopefully we can shed some light on a pretty rare and difficult problem of dysplastic tricuspid valve, severe TR, and pulmonary atresia in a newborn. First of all, I needed a little clarification about what exactly we were talking about this morning, because there are several disease entities that one could be referring to here. But today, we're really talking about a baby with pulmonary atresia, intact septum, and severe TR. And let's see, how can I, there we go. Here we go. So these patients typically will have they'll be prenatally diagnosed most often, have a pretty large compliant tripartite RV, a large tricuspid orifice, dysplastic tricuspid valve, but mobile definable leaflets with, of course, severe right atrial enlargement. That is importantly not confused with pulmonary atresia intact septum of the usual variety, a competent tricuspid valve with attendant right ventricular hypertrophy, varying degrees of RV hypoplasia, tricuspid annular hypoplasia, which those things together, of course, drive a decision regarding potential biventricular repair versus single ventricle palliation. And also, this clicker's not, there we go. Not to be confused with neonatal Epstein anomaly with pulmonary atresia, obviously a very challenging lesion in and of itself. Downward displacement of the tricuspid annulus, failure of delamination of the leaflets, varying RV size and function, importantly, and of course, atrialized portion of right ventricle. So it's day 2 of life, a newborn baby on a ventilator in your intensive care unit, marginal cardiac output perhaps, marginal saturations, and everybody looks at you and goes, well, what are we going to do with this? Obviously, fundamentally, that's a choice about biventricular repair strategy versus single ventricle palliation. And I would submit that in this particular anatomy with a good-sized RV, a large tricuspid orifice, and these definable tricuspid valve leaflets, that biventricular repair is going to be the appropriate choice in the vast majority of patients. That isn't to say there isn't a role for a single ventricle palliation a la Starnes procedure, but this talk I'm going to focus on the biventricular repair pathway. I know that Ram Subramanian's somewhere in the audience, and perhaps he could comment a little bit on the role of Starnes procedure in this particular disease entity at the end. First of all, how many of these patients are out there? If this is table 8, most frequent diagnoses in neonates last 4 years, pulmonary atresia intact septum, less than 50 cases a year across North America. And if you look at tricuspid regurgitation non-Epstein's, it's less than 10 cases per year in North America. So we're not seeing this very often. And when we do, we don't have a lot of choices of what to do. If you look at the procedural table 9, tricuspid valve repair was undertaken in neonates in the last 4 years in North America about 10 times a year, and the mortality rate is 11%. Tricuspid valve replacement in neonates, 2 times a year that occurs in North America, and the mortality rate is about 14%. So rare and challenging. If you look at the literature for advice about what to do, it's likewise pretty sparse information. This report out of Osaka, 12 neonates for either Epstein or non-Epstein tricuspid valve disease. Only 3 of those patients had tricuspid valve dysplasia. One of them underwent a conventional type repair. 2 patients underwent cone procedures. One of those died. Similarly, Ramamani's retrospective international multi-institutional report a little over a year ago about AV valve regurgitation using the Melody. Of 68 patients, only 9 were tricuspid valve replacements. 2 of those, or 4 of them, sorry, were relevant to this particular conversation in anatomy. 2 with congenital TR, 2 with pulmonary atresia intact septum. Of those 9 tricuspid valve replacements, 4 of those patients died and 1 underwent transplantation. So again, suboptimal outcomes to be sure. And then just to be complete, the CHLA's report, Ram, the first author on that, regarding Starnes procedure for neonatal Epstein's, importantly. The thing that leapt out to me here was 25 patients accrued over a 26-year period of time. So again, low volume, an admirable operative mortality rate of 13% in a real challenging lesion, and even more remarkable, I think, little to no late attrition in that patient cohort. But again, no information about this operation for the disease we're talking about this morning. So in terms of biventricular repair, what are the key things we need to accomplish? Well, first of all, we need complete relief of right ventricular outflow tract obstruction. That could be in the form of valvotomy, a right ventricular outflow tract patch, or an RV to PA conduit, a competent valve in a patient who perhaps for whatever reason is suspected of having significant pulmonary hypertension. But most of the time, this is going to be a right ventricular outflow tract patch with or without a monocusp. Secondly, of course, we need to create a competent tricuspid valve. In a neonate, of course, that's repair and repair and repair, either using conventional techniques or I think I'll try to make the case today that a cone or modified cone, importantly, is probably the best choice. When all else fails, tricuspid valve replacement, again, in a neonate, probably a melody valve, in my opinion, but a challenging situation. And then lastly, I would mention that I believe that avoidance of pulmonary hypertension perioperatively and subsequently is an important thing in these patients. So liberal use of perioperative nitric oxide and discharge on a pulmonary vasodilator is probably a helpful adjunct. I just want to point out when this detail about modified cone procedure, these reports by Emery Belly on the left and Joe Deraney's group on the right, illustrating augmentation of various portions of the leaflets in the cone, septal leaflet on the left, anterior leaflet on the right, and I think this is important to mention in this particular anatomic setting because these leaflets will very often have deficiencies in surface area that can be helped by these augmentation patches. Thought I'd share our experience at Children's of Minnesota through 2018. The top line's wrong. So over roughly a 10-year period of time, we saw 5 patients that would fall into this category for pulmonary atresia intact septum, 1 congenital TR, which isn't exactly what we're talking about, but all 5 of those patients underwent conventional repairs. However, 2 failed early, and we used the cone for those 2 patients. Fortunately, we dodged 5 bullets here, but it is a challenging situation. So I thought I'd take you through a case study illustrating, hopefully, the principles we've talked about here. So this was a prenatally diagnosed male born with severe tricuspid regurgitation and tricuspid valve dysplasia, pulmonary atresia, severe right atrial enlargement, severe cardiomegaly by X-ray, and immediately after birth, SATs in the mid-70s on a ventilator and modest inotropic support. My colleague, Dr. Frank Moga, took him to the operating room on day 5 and using conventional techniques, eccentric suture annuloplasty, primary repair of some hyphenations in the free edges of the leaflets, and what he called edge-to-edge repair, which really, I think, was stabilization of the septal leaflet to the adjoining anterior and posterior leaflets. Pulmonary valvotomy was used because of a good-sized pulmonary root and well-formed sinuses and good-looking valve cusps. Reduction right atrioplasty, and the ASD was closed. And at the end of that operation, you can see moderate tricuspid regurgitation, but with low RV pressure and a peak gradient across the outflow tract of 16 torr. Saturations were 100%, and the baby did reasonably well, being discharged 3 weeks postoperatively. However, 3 weeks subsequent to that, the baby represented to the hospital with increased work of breathing, SATs in the 70s, symptoms of an intercurrent URI, and now severe tricuspid regurgitation with a mean gradient across the valve of 11 torr. And importantly, the peak gradient across the right ventricular outflow tract had risen to 45. So we returned to the operating room with that baby and did a cone. You see the post-repair echo here. And we were pretty happy with that. Mild to moderate TR, a mean gradient across that valve now of 2 torr. And we performed a a right ventricular outflow tract patch, which gave us laminar flow in the right ventricular outflow tract, albeit with obligate-free pulmonary insufficiency. This is his pre-discharge echo, and you can see an increase in the tricuspid regurgitation, now a solid moderate, but the baby was doing well, went home. And now his most recent clinic echo, 8 years subsequent, shows by 2D pretty good leaflet motion, kind of tentative coaptation, but seems okay. But if you look at his color flow, he's got severe tricuspid regurgitation now. It's a relatively narrow vena contracta, but that's going all the way back to the free wall, and definitely severe tricuspid regurgitation. He's asymptomatic, but we'll clearly need reintervention on that valve at some point. So what are the takeaways for me with that? Well, number one, it's an exceedingly rare disease, and the current outcomes are suboptimal. There are important anatomic differences in this entity as compared to pulmonary atresia intact septum or neonatal Epstein's, and those differences favor biventricular repair. Experience with neonatal cone is limited in this setting, but in my opinion seem promising. Complete relief of right ventricular outflow tract obstruction is very important in this setting when the primary challenge is to produce and maintain a competent tricuspid valve. And finally, therapy to mitigate pulmonary hypertension may be a useful adjunct in these patients, and I would recommend its use. So that's my summary. I'm happy to entertain any questions. Thanks for your attention. And Ram, I think if you could comment on Starnes and role of Starnes for this disease, that would be great.
That was a terrific presentation of what is a rare lesion, but we had a patient exactly like this about 3 or 4 weeks ago. And we spent a lot of time in cath conference with me telling people that I thought we should do the operation you just described. And I was talked into putting in a conduit. And I was talked into it without a great deal of reluctance on my part, but I sort of have this rule in my mind that on each side of the heart you really need to have one valve that works. And I think that you didn't have one valve that worked. And the other thing is I was a little surprised you did okay without an ASD. I would, in this kind of a case, knowing how well or badly, in fact, I repair tricuspid valves in neonates, I'd always leave an ASD. But two things I want to just sort of mention, having mentioned a bunch of other things already. One of them is that it's worth pointing out that for what we all know, which is that an AV valve will never look better than it does in the operating room with an open chest under general anesthesia. And so it's very important that you be sure that your echocardiographer puts the report in a PDF so it can't be altered later, so that everybody can see that at one point there was happiness. But so that I think is really crucial to think about having at least one competent valve. Now the kid that I just operated on is going to need lots of future work, and my tricuspid valve looked just like yours. It leaked a lot, moderately when they went home, even though it was fine initially. But the difference between this lesion and Epstein's is that Epstein's, it's worth pointing out, is a disease of the right ventricle.
Yes.
And these kids, if they have tripartite right ventricles, have valvular heart disease, and we should do everything we can to preserve their ventricular function, even if it means a lot of valve operations, to prevent them from developing right ventricular disease as well. And anyway,
yes, I 100% agree. I was trying to say that, but you said it better. I think the residual disease, and I would say the takeaway from this case, that original echo, that was moderate TR at the end of that, and that's going to get worse. And so you really we probably shouldn't have left accepting that, And then, of course, your point. So at that point, the baby had a competent pulmonary valve after valvotomy. So that was the strategy there. But you're quite right. You can't have two leaking valves. You're not going to do well.
Jake, I would add you may want to record what the echocardiographer is telling you in the OR to make sure it correlates with what they put in the PDF.
Great presentation. One little point. The fact that you are going to do a STARNS to get out of the neonatal period does not preclude that you cannot come back in the future and do a cone procedure. If you do the STARNS in a way to preserve the valve leaflet and be careful where you suture it, then the ventricle recovers, you get out of the neonatal period, you improve the diastolic function of the left ventricle, and then you come back in order to take down the STARNS and try to do the cone procedure.
Have you done that? Do you have experience with that?
I have done that in one patient who, in addition, had a dynamic right ventricular function and a very thin ventricle. The kid survived 6 months, and we were ready to do that, but then the kid had a sudden event at home and succumbed. So I haven't completed that. I would be very interested to see what the Los Angeles group, whether they have seen that. But the same way that when you have a borderline left ventricle, we all try to make the decisions early and try to do everything, the mitral valve repairs early, and then Ram showed all of us that you can temporize things and do them later. I wonder whether that would be a better strategy.
Ram, you're up.
Nice talk, Dave. That was great. I'm here to echo exactly what you and Jake was said. So our experience in Los Angeles would completely agree that in Epstein's anomaly, it's a ventricular disease, not a valvular disease. So in that setting, you can have a valve that works in any way you want it to, but the ventricle is innately incapable of sustaining pulmonary circulation. And because most of our patients have been like that, we've not been able to take down the STARNS patch and then repair the valve. Like in our circulation paper, we were able to show, we go and put the patch and punch a hole in it. The next day, that RV just shrinks down and has like a 10 millimeter gradient leaking back into the right atrium, telling you that that ventricle is innately incapable of maintaining systemic circulation. Sure.
Right. But do you have experience, though, in this disease entity with
Good
STARNS?
question.
How many patients have
We've only had one patient in whom we were able to repair the tricuspid valve in this condition. But to go back to what you said, the decision of saving that ventricle and valve depends on what the ventricle looks like. A tripartite, like Jake was just saying, tripartite ventricle that's capable of circulation should make every attempt to save it. Contrarily, if you have this hypertrophied little pit chamber with only, an inflow segment, we had one of those as well, and I think that's a different disease. Their tricuspid regurgitation is not the primary problem, it's a primary ventricular problem.
So in other words, it's rarely, if ever, used for this disease.
Rarely, if ever, used.
Yeah.
I think, David, one of my concerns about these repairs, which are very, very challenging to do, is creating tricuspid valve stenosis. Because typically these valves either have mild or moderate hypoplasia to start with. Even if the ventricle is not completely normal size, we're trying to preserve that by ventricular repair. But any particular tips in terms of avoiding, development of tricuspid stenosis?
Well, I think typically you'll start with a tricuspid annulus that's dilated, if anything, in these patients. So it's a little different that the tricuspid annular hypoplasia patient, like you're talking about. But that said, I think it's important to pay attention to your Z-scores, pay attention to when making the cone that the effective orifice isn't too small, and modifying the cone with augmentation patch material helps avoid that. Those would be, I guess, the two things I would say about that.
Gus?
Thank you. That was a great talk. There's one thing, however, that we haven't talked about, and that is the role of the bidirectional Glenn here, the so-called 1.5 ventricular repair. And while there are a myriad ways of dealing with these problems, one might consider the problem of fixing a valve and making it too small, converting a regurgitant valve to a stenotic valve. And one way of dealing with that is to just accept it as long as it's not regurgitant, and then do an ASD, and if you need to, do a shunt, and if you need to, come back later on and go towards a 1.5 ventricular repair. I wonder what your thoughts are about that. Very nice presentation and great discussion.
Thanks. Yes, I would worry about cardiac output in a 5-day-old or whatever with significant tricuspid stenosis, that you'd end up with kind of unsustainable cyanosis and stuff like that because of the atrial level shunt. But yes, I think creating competence and tolerating, say, moderate tricuspid stenosis is certainly, perhaps, yeah.
Thanks so much.
Thank you.
Rare but interesting topic that we're all going to come across. Our next speaker is Dr. Rusty Eckhauser, and he's going to talk about a problem and share his insights about pulmonary vein stenosis following single ventricle palliation. So, Rusty, nice easy topic that we assigned you.
Thank you both very much for the invitation to talk today. So I'm going to talk about pulmonary vein stenosis following single ventricle palliation. And this has been an interesting talk just because we don't see it a whole lot. So we'll get started. I don't have any financial disclosures or of any nature. So I thought I'd start with a case. We don't see this a lot, but this was a baby that I took care of recently. He was a full-term male. He was born with double outlet right ventricle, had mitral atresia. By the time I operated on, had severe TR with a dysplastic tricuspid valve. He had stenotic branch pulmonary arteries, and it was a right aortic arch. So I did a Norwood with a bilateral PA-plasty. I did a tricuspid valve repair and a left-sided BT shunt. And he came off bypass with good function and trivial TR. But over the next month to two, he went right back to severe TR. And his course was really defined by progressive hypoxemia. He had a chronic chylothorax, ended up doing a thoracic duct ligation. He had very abnormal lungs on X-ray, CT scan, and the parenchyma when I was doing it. So I did a lung biopsy at the time, which just showed some nonspecific pulmonary inflammation. So because he had failure to progress, we ended up doing a cardiac catheterization, and this is kind of the image that we found, is that his EDPs weren't that bad. And there was about a 2 millimeter gradient from both veins to his common atrium, but you can see he had pretty significant pulmonary hypertension with a mean PA pressure of 27. So we'll come back to this at the end. And then this was his CT scan. So on the image on the left shows the right pulmonary veins as they course behind the common atrium and the right aortic arch. And there's a little indentation. It's not bad, but there's not much upstream dilation of that right side. On the left, or the right-sided image, you can see, really focusing on the left vein, you can see there is an area of narrowing as it comes behind the heart. So conceptually, as I was thinking about these patients, I kind of divided them up into two groups. One was single ventricles that have total anomalous pulmonary veins and those that don't. I think the group with the total veins it's very complex and heterogeneous, and it's really speckled with a lot of patients with heterotaxy, and that's a complicated topic for today, so I elected not to talk about that. But today we just focus on the patients that did not have total anomalous pulmonary veins. So for myself, as I was trying to better understand this, it was helpful for me to think about the relationship between the timing of occurrence of disease and the cause of the occurrence. So in relation to timing, this could happen at the first palliative surgery, whatever it is, in the interstage period at the timing of the second or third palliative surgery. And then similarly, in terms of causes, I kind of broke this down into 5 etiologies: osteostenosis of the pulmonary veins themselves, if you have an obstruction between the left and the right atrium, intraatrial baffle obstruction, compression from an extracardiac conduit, and this thing that we've called in our institution the Catani effect. So I thought we'd spend a few minutes on each of these etiologies, focusing first on the osteostenosis. So this is an extremely rare disease. Dr. Spray, I talked to him quite a bit about this just because I haven't seen a lot of this in single ventricles. And they really encompass just a fraction of the kids with congenital cardiac disease. And they have a very varied presentation and typically occur within the first 6 to 8 weeks of life. And these can happen unilaterally with one vein, with 2 veins, or it can be bilateral with all veins involved. And what it fundamentally represents is an intrinsic abnormality with intimal fibrosis of the pulmonary veins. So this is a bad problem, especially in a single ventricle. Unfortunately, we do not have good therapies to treat this surgically. I think the most applicable and accessible thing we could do at the time is a primary sutureless repair, as that's become a little bit more of a comfortable operation for people. The group in Toronto presented their experience using the sutureless repair for primary pulmonary vein stenosis, and they were discouraged by the high mortality rate and the restenosis rate with that operation with this disease. So the mortality rate for their entire group was about 40%, and the restenosis rate was upwards of 30%. So it also, their experience reflected the fact that this is an intrinsic vein problem that surgery is not always capable of fixing. Dr. Spray talked about his experience with the heart-lung transplant. Obviously, this doesn't happen quickly, but this was why he started doing lung transplant, was to address some of these pulmonary vein stenosis problems. And while he did have good success with some of these, you know, there's a lot of morbidity that can occur on the wait list, and also it's not a really durable operation in the long run. So next I looped narrowing of the left atrial outlet and baffle obstruction into one etiology. So narrowing of the left atrial outlet, this is kind of associated with interatrial septal, or the interatrial course of the pulmonary veins. And so in 2004, the group in Boston, they did present their experience. So they had over 1,000 patients that were single ventricles that went through the Fontan completion. And out of that group, they identified 3 patients that required a re-intervention for pulmonary vein stenosis or obstruction. They were all lateral tunnel Fontans, none of which had initial obstruction. Their 3 patients occurred late, 8 months, 23, and 42 months postoperatively. And as a result of their experience, they modified their surgical techniques. And subsequently in follow-up studies, they'd shown that it's an extremely rare incident that this would happen. So how did they address this, or how could we address this surgically at the time? One is that you could go back in and further resect septum, whether it was an incomplete resection at the initial operation, or sometimes that interatrial septum just gets a fibrotic remnant that could be resected. The other option, and this is what they adopted, was that they now unroof the coronary sinus quite far into the left atrium to really ensure that you have a wide open pulmonary venous outflow. And this was really important for patients with mitral stenosis or atresia, because they already have small atrial cavities anyways. So this is a still image from the Boston group. You can see the picture on the left shows a patient after a lateral tunnel Fontan. The PVO, pulmonary vein obstruction, but that's the left atrium. The CAs, their common atrium, and this was a lateral tunnel Fontan. And then they closed the fenestration in the cath lab with a CardioSeal device. That's what that is. But you can see the aliasing around the pulmonary vein coming into the common atrium. And all they did in this operation was they went back and they unroofed the coronary sinus into the left atrium. And you can see on the right, you have pretty laminar flow through that pulmonary vein. This was also an experience with 2 patients out of Japan. So these were both heterotaxy patients, single ventricles at the time of the Fontan. Both of these patients got a completely intracardiac Fontan graft. And both of them presented acutely postoperatively with severe decompensation, requiring surgical reintervention. But if you look at this picture on the right, you can see the grafts labeled IAG. Posterior is the left atrium. The graft sitting right in the communication between the left atrium and the right atrium, and there was obstruction there. And what they found was that they didn't think this was inherently a problem with the operation, but it was really individualized to the patient's anatomy. And so this was affected by not only the conduit orientation within the heart, but the conduit size, the baffling or the suture line placement of the baffles, and also in one of their patients, there was a pretty significant fibrotic reaction between the graft and the remnant of the interatrial septum, causing some obstruction. So how can we treat this one surgically? If this happens, I think there's several options here. One, you could go back at the time and downsize to a different interatrial conduit that's smaller. I would probably consider converting to an extracardiac conduit or an extracardiac conduit, depending on where the IVC sits and where it needs to come out. And what they did in their second case is they just took this down to a Glen, and then they brought it back and did an extracardiac Fontan later. The third etiology is compression from an extracardiac conduit. Now, in training, this was something that we were always taught to focus on and think about. And I have to say I never saw it in training, and I have not encountered this in my practice, but I do actually spend a lot of time thinking about it during the operation. So it's extremely rare. I found no incidences of this in the literature. But when I think about it, it's really an interaction of graft size and patient size. So a lot of people are really trying to use these 20 millimeter grafts. And if you have a child that's under 12 kilos or under 2 years of age, it's sometimes challenging to get something that big. And the other thing is graft length. I think if you undersize the graft and make it too short, you can really bowstring the right-sided pulmonary veins. And I also think about the site of implantation. Is it done really on the inferior aspect of the RPA, or is it brought more anteriorly near the glen? And so with this complication, this is how I would envision treating it, is either revise the graft, make a smaller graft with some longer length, and potentially move my anastomosis more anteriorly onto the RPA. Like I said, secondly, you could downsize the conduit. I don't typically use 20 millimeter grafts. I use 18 millimeter grafts, but there's actually reasonable data that 16 millimeter grafts are actually adequate and acceptable for this operation. Or you could convert this to a lateral tunnel or an extracardiac conduit. And then finally, I've labeled this the Catani effect. Dr. Catani was the lead author on this paper, but that's just what it's been called in our institution. So this is a phenomenon where the left-sided pulmonary veins in single ventricles become obstructed. And it really happens as a vice between relative cardiomegaly and an anterolaterally displaced aorta. So this group, which is based out of the UK and Toronto, what they did is they took about 500 single ventricles. They excluded all patients that had total anomalous veins. And they queried it for pulmonary vein obstruction, left-sided pulmonary vein obstruction. They had 24, and they eliminated 9 because they wanted to really compare echo and cardiac MRI. So they had 15 patients in their group, and when they compared the groups, they found that the obstructed patients had a larger cardiac cross-sectional area that was normalized to the thoracic cross-sectional area. And also, not only on CMR did they see pulmonary vein obstruction, but what they saw was there was a significantly increased amount of relative blood flow to the right lung compared to the left lung, further indicating a problem. So out of their 15 patients, they took 7 of them to the OR for obstructed veins. All of those patients received a sutureless repair. So 4 of them did very well, meaning that they had no further pulmonary vein obstruction. 3 patients had equal pulmonary vein obstruction, and 2 of them died. And so in total, out of their 50% of the patients failed to progress to a Fontan completion. And this is a picture that they presented. So the picture on the left in A, it shows, the arrows show constricted left pulmonary veins between the heart and this anterior displaced aorta. The right-sided labeled B shows the vein being more patent after a sutureless repair. And so the option would be a sutureless repair here, with the focus being that you really extend the confluence beyond the plane, the anteroposterior plane of the aorta, so that you're actually resolving the obstruction, that you get beyond it. You don't do a sutureless repair within the confines of the aorta. Another potential option is an aortopexy, although I think this would probably be less efficacious. If you could get a good mobilization of the aorta and really tack it down to the paravertebral fascia, possibly that would be a benefit. And then a theoretical benefit that they discussed too is that not necessarily doing anything anatomically, but going in earlier to repair lesions contributing to volume overload like tricuspid or AV valve regurgitation. So in summary, what they found was that ventricular volume overload, ventricular dysfunction, AV valve regurg, these 3 things in association with an anterolaterally displaced aorta would promote left-sided pulmonary vein obstruction. So when I put all that together, thinking of timing and etiology of pulmonary venous obstruction, so when would I expect to find osteostenosis? Typically, it could occur early in the first 6 to 8 months, but theoretically, this could happen at any time in palliation. The narrowed left atrial outlet, I would assume, would happen more commonly in the second operation, but it could happen at the 3rd stage palliation. Similarly, the extracardiac conduit would occur at the 3rd stage, and then the Catani effect could happen at all stages of palliation. So once you've sort of parsed through the etiology of the pulmonary venous obstruction, I think you really need to spend some time thinking about whether surgery is warranted or not. And if you do, these are some of the factors that I think could help influence that decision.
So clinical presentation obviously is important. Are these patients chronically hypoxic, or do they have worsening hypoxia? That would certainly be a problem. Do they have isolated one-sided pulmonary hemorrhage or signs of systemic venous obstruction? When I talked to Dr. Spray about this, because he does have quite a bit of experience, we really talked about the importance of measuring pulmonary vascular resistance. So even in the setting of relatively normal angiographic findings, if you have elevated pulmonary vascular resistance and pulmonary hypertension, and really it's indicative that much, if not all, of the pulmonary vascular bed's involved. In the absence of pulmonary hypertension, this to me would indicate that only a portion of the vascular bed's involved. And then similarly with pulmonary flow distribution, so one of the things that the Catania group found was that there was really poor correlation between echo findings and CMR findings for pulmonary vein stenosis in this cohort. And they felt like part of the reason was because echo underestimates the pulmonary vein obstruction, because you'll get an increase in pulmonary blood flow to the other side and the gradient's potentially lower. So I think CMR is really helpful to find out if you have an increase in right-sided pulmonary venous flow. And then obviously critically important is, what is the pulmonary venous anatomy? If you have bilateral disease and pulmonary hypertension, surgery is nearly always unsuccessful in the long term for these patients. If you have unilateral disease and no pulmonary hypertension, perhaps watchful waiting's more prudent, although surgery can have variable successes. And if you have a discrete obstruction at the veno-atrial junction with some upstream pulmonary venous dilation, this would probably be the case that you'd expect the most improvement from with a sutureless repair. So back to the patient that I had, like I said, had severe tricuspid regurgitation with significant pulmonary hypertension, had a 2 millimeter gradient by cath, and we would consider 4 to have been hemodynamically significant. So at this stage, we didn't think he had severe pulmonary hypertension or venous obstruction. So he ultimately underwent an orthotopic heart transplant. So this is what we found post-operatively. You see the CT scan. This is several months post-transplant, but the right-sided veins look reasonable. And you can see that left-sided veins compressed pretty significantly between the mass of the heart and the spine. And at the time of the transplant, he was noted to have extremely small orifice of both left upper and left lower pulmonary veins. So he currently has a 6 millimeter gradient by echo. He's intermittently tachypnic. We're awaiting a hemodynamic cath and cardiac MR to really evaluate pulmonary blood flow. And right now, we're just really trying to understand whether a sutureless repair would actually benefit this child at all. So this is a tough problem, and this is something that we're seeing a little bit more of, but we don't have a great solution or an answer. Thank you very much.
Rusty, excuse me, that was terrific. It's a difficult problem. We all see it in various stages of single ventricle palliation, and that was a really thorough sort of overview about what's out there. Chris?
Aaron, that was a fantastic talk. Obviously, for good or for bad, we see a lot of these patients now, and I think you've described the fundamentals of a lot of it, but I think we have missed the boat for a long time. And that concept of the Catania effect, if you will, if you really take all of these patients with pulmonary vein disease now and look at the external surrounding structures and the way these veins anatomically come in, these are set up for shear stress and obstruction in the intravascular part. And you put that together with actually excess pulmonary blood flow, now you have a setup for this perpetuation, if you will, of this osteal obstruction. So it's pretty predictable, actually. And the two things that are critical to us now are looking at the external anatomic structures and how we can reconstruct them. So we rarely ever do a sutureless repair anymore because that doesn't really fix the problem. But you can actually move the pulmonary veins. That last CT you just showed, if you take that pulmonary vein and move it laterally and up and change the angle of it, then you take away the osteal, or the nidus, if you will, for shear stresses that perpetuate this osteal obstruction. And then if you take those single ventricle patients and you put a shunt in there as a neonate and you oversize the shunt, and now you have excess pulmonary blood flow and a little nidus at the ostium, you've just perpetuated the problem. So you can clip that shunt down and actually take the gradient away and slow the pulmonary vein disease down. So I think you hit on a lot of important concepts, and we're thinking about now when we look at these pulmonary vein patients, how can we externally reconstruct the veins, if you will, so they come in unobstructed and limit the pulmonary blood flow, or really optimize it?
Chris, if I could ask you while you're at the podium, just a quick question about the use of the superglen for patients with concomitant pulmonary vein repair.
Yeah, so we've used the superglen, and for those who aren't familiar, it's where you're adding a shunt, if you will, to the affected side and leaving a glen anastomosis or cava pulmonary to the unaffected side, if you will. So in one type of patient we've used that in is patients with pulmonary vein disease, and it's really difficult to get that flow right, if you will. But the concept is if you have developed complete atresia, say on one side, and you can open up that pulmonary vein, you now have to reestablish blood flow to a high resistance lung. And to do that, you have to provide a higher pressure. So we'll add a shunt to the left side and let that lung develop over time. And so that's one of the situations we've used a superglen, and it's been reasonably successful in recruiting that affected lung.
Great. Jake, and then we see Chris Calderon in the back that we're going to ask you to come up and make some
I'll
comments.
try to be fairly quick. I first want to say, Rusty, that's the best presentation I've ever seen on pulmonary veins. It was superb. Thank you very much.
Thank you.
I want to pick up on a couple of points that you made during the talk at various points. One of them was about this Catani effect and the ability of echo to discern that there's a problem there because of the fact that pulmonary blood flow has someplace else to go. And I think that's particularly important in the area of thinking about the extracardiac conduit and its relationship to the right upper pulmonary vein. That's an area that, as Chris was just talking about, is very tightly constrained by other anatomic features. The interatrial groove may not be developed, and you can do that surgically, but you have a hinge of pericardium, which you showed and Chris just talked about as a lever. And I think far more often than we realize, we put an extracardiac conduit in. Our echo colleagues tell us there's either no velocity increase or a mild one, and we are falsely or inappropriately reassured by that. We have no idea how the blood flow is distributed in a Fontan postoperatively right and left unless we happen to have done an MRI. And I think that if we did MRIs on a lot of these patients, we would find very subtle and not acutely important differences in how blood flows. Our larger lung is being compromised, a significant part of it, the venous drainage, and we don't know that because it's going to the left lung. But I think that's one of the subtle reasons that can contribute to Fontan failure. If we don't know how blood is flowing left to right, we really don't know whether we've got obstruction. I'm paranoid about this, beyond paranoid. It's one of my many idiosyncrasies, but one of the things I always do with an extracardiac conduit is I cut the pericardium posteriorly, as people used to do with lung transplants. I don't do that operation anymore, so I don't know if people still do. That gives the right pulmonary vein a place to drop posteriorly, sort of frees it up. Something I think about. I don't know if it means anything. But.
No, I appreciate those comments. There have been times where I've undersized and it looked like I was tethering, and so I've done this similar things and really freed up the right veins. I think Dr. Calderon, you're the senior author on that paper. You could comment on the discrepancy with echo and CMR with pulmonary vein obstruction, perhaps.
Well, it's important. Basically, you cannot count on an echocardiogram to detect recurrent disease. And if you wait till it's apparent with the echocardiogram, you've probably waited too long. The flow redistribution just makes echo gradients essentially useless. And that actually leads to the comment I was going to make is, you're kind of pessimistic, and I don't think we always need to be quite so pessimistic about pulmonary vein stenosis, but what we need to do is reset our expectations. A patient like you described with congenital pulmonary vein stenosis is very unlikely to be cured by an operation. But what I think the strategy we're starting to evolve to is you relieve obstruction as best you can at the veno-atrial junction. You treat pulmonary hypertension because that's your opportunity to really do it aggressively. And you have an expectation that you're going to be in the cath lab in a month. And you just keep hammering away over and over and over again in the cath lab to basically deal with your recurrence that's expected. If the recurrence is expected, it kind of changes the mindset of the team as a whole. And, to take it to an absurd extreme, if you dilated the pulmonary veins every single day, the recurrence would never happen. Well, obviously we can't do that, but a scheduled plan of surveillance to detect disease that progresses silently on the clock rather than waiting for symptoms. Aggressive treatment of pulmonary hypertension when you have that window to do it, and an expectation that you're going to keep dilating and dilating and dilating over and over again with stents. If you can get the stents up over 7 or 8 millimeters, there's a good probability those veins are going to stay open for a long time. Last part is some systemic therapy, whether it's Gleevec, Avastin, losartan. Hard to tell what might actually be the magic sauce that helps us with the disease around the capillary level. But I think a combination of all these is what we're going to actually end up landing on, although it's going to take a little while to get there. I'll put in a plug for Rachel Vanderlane, who's put together a pulmonary vein stenosis registry, now 600 patients. And when we start really being able to work through that clinical data, then we're really going to be able to, start figuring out how to orchestrate these various components of therapy in some cohesive whole.
No, thank you for the comments. I appreciate that. I do think that most of us that don't spend a lot of time on pulmonary veins, we really wait for the disease to show its head before we go looking for it. And I didn't even dig into stenting and the therapies for stenting. I just focused on surgical therapies, so that's something I didn't really touch on today at all. But I do agree with you that if it is somewhat mindset, but thank you.
Great. Last comment from Carl Backer.
That's my exact question. I mean, our cardiologists always want to go after these with stents, and we're seeing those placed more and more. Maybe you could, I know you didn't touch on it, but it's become a big part of the potential therapy.
I'm probably the wrong person to ask. I don't know, Chris, if you have experience working with stents, but we have not, we've not pursued stenting. We've tried drug-eluting stents, bare metal stents. We've tried other things with not tremendous success, and I don't know what success is defined as, but we just haven't used it a lot. Chris?
Yeah, so we have a joint experience, if you will. We work pretty closely with our cardiologists on a case-by-case basis. And again, I think it's where they present in the disease state, and depends on exactly the timing of the intervention. And Al actually supported a catheterization-based stent. If you see that long pathway from the atrium to the left vein, and you need to get the patient better, they're too sick for an operation, if you will, there's no problem with putting the stent in there and dilating it over time. And as Chris alluded to, going back, and at some point they may need to come back for an operation. I'll just remove that stent, exclude it, cut it out, and then reposition the pulmonary vein so it really doesn't affect the operation I'm going to do in the future. So I think the stenting and drug-eluting stents actually also probably perform a little bit better. We're collecting data on that. I think the key is where they're positioned and how they're placed. When they start occluding other branches or subsegmental branches, now you're introducing disease that doesn't have to be there. Secondarily, we're now using short intraoperative stents of just several millimeters long to hold open these micro anastomosis, if you will, on the neonates and young infants that we're doing vein repairs on, just to hold open the anastomosis so you don't get turbulence because they kind of involute on themselves.
Thank you so much, Rusty. That was an excellent presentation. Appreciate it. I'd like to invite our last speaker. Ram Subramanian is here from Children's of Los Angeles to talk about an inability to wean from cardiopulmonary bypass after the arterial switch operation.
Good morning. Thank the society, the moderators, and all of you for this opportunity to present. I'm here to talk about the inability to wean from cardiopulmonary bypass following an arterial switch operation. I have no relevant financial disclosures or off-pump use, off-label use. Repair of transposition has come a long way, right? As we all know, it started off in the form of a physiologic repair where the switch was done at the atrial level. And in this operation, there was no involvement of the outflow vessels or the coronaries. As we switch to the arterial switch operation, which is the most commonly performed surgery today for DTGA, this changed the way we approach the coronaries and the semilunar valves in this disease process. Today, this paper from Tara and the STS database shows a very low mortality and very acceptable morbidity following an arterial switch operation. Despite this advancement, surgical complexity persists, and it's primarily driven by the underlying anatomic heterogeneity in the transposition anatomy. So, the inability to wean from cardiopulmonary bypass, the exact incidence is not known. I don't think somebody's going to write, in so many cases I was not able to come off pump, and so I went back and refixed it. So I don't think literature is going to help us understand the true incidence, but we can all agree that this happens. And this happens with a frequency that we need to know how to address this in the operating room. So as I thought through this, I thought there were 3 groups of lesions that could preclude us from safely weaning from cardiopulmonary bypass. So one big group of lesions, and then a couple of little groups of lesions. So if I had to summarize this entire talk in one word, and that would be coronary. Inability to wean from cardiopulmonary bypass, as we said in one of those cheesy titles of an editorial I wrote with my fellow, coronary transfer is the heart of the matter. The other problems could be neo-aortic root pathology or neopulmonary root pathology. So I'm going to go through this individually, but the majority of the time is going to be on understanding coronary problems following arterial switch operation. Coronary problems are very common in the so-called complex arterial switches. So here is a long list of the more complex anatomic variations in transposition. Either it's transposition with side-by-side great vessels or an anomalous coronary pattern, or the switch that's done with an arch and a VSD, or a complex double outlet right ventricle variant like Tausig-Bing. So this is a disturbing echocardiogram, right? You're done with your transposition switch operation, you take the clamp off, you're trying to wean, and this is the TEE that you see. Coronary insufficiency following arterial switch operation relies on a very high index of suspicion. In other words, what we joke about with our fellows in Los Angeles is, if you can't come off pump after an arterial switch operation, it's a coronary problem until you prove otherwise. And the decision to fix it is then and there in the operating room. These most often should not be post-operative MRI cath diagnoses. These are handled then without leaving the operating room. And they could present in a myriad of ways. Sometimes it's obvious, like this echo, where your heart's not moving. You have bad function or regional wall motion abnormality. Sometimes it's just left ventricular dilation after you remove the vent, or bad mitral regurgitation, but all of which should point to coronary insufficiency. So this is a relationship between anomalous coronary patterns and aortopulmonary relationships in transposition. So there's a well-recognized variation going from the so-called standard setup, where the aorta is straight anterior to the pulmonary artery, that's the setup 2, in which case the overwhelming majority, 81% of the time, is the usual coronary pattern. But as we transition from that to the setup 5, which is a true side-by-side great arteries, over 70% of the time the coronary pattern is anomalous. And the anomalies could be intramural, single, inverted, or any combination thereof. And in the setting of these anomalous coronaries, postoperative coronary insufficiency is far more common than in the more routine pattern. The standard approach to switching coronaries, for example, when there's an anteroposterior relationship, we use the so-called owl's eye technique, where we take buttons of coronaries from now the neopulmonary route, move it to the neo-aortic route. And in this picture, it's shown as a U-shaped incision made in the neo-aortic route. We tend to make punch holes, leaving a little bit of aorta on the top as well. And we use autologous pericardium to reconstruct the neopulmonary sinus. While this will work in the vast majority of cases, if after the switch operation there is coronary insufficiency, there are some standard techniques that one can utilize to revise the coronary anastomosis in order to improve coronary insufficiency. I'll start off by trying to understand what the coronary problem is. It could either be an orientation of the coronary, or where the coronary was positioned, or how the neo-aorta and neopulmonary artery were reconstructed, leading to inadequate blood flow into the coronaries. So as the picture shows, the coronary could be kinked, the coronary could be stretched, and some of the ways to approach these would be, number one, you could resite the coronary arteries. As shown here in this picture, especially for a right coronary, it's quite frequently a more superior, a higher location on the reconstructed aorta to keep it from kinking and from having coronary insufficiency. There are many ways to do it, and this is one of the techniques that Frank Lacourgaille said in his presentation about including the bottom of the right coronary into the aortic anastomosis and then stretching it up into the distal aorta to position it in a higher orientation. The other way to do this is to use the so-called medial-based J-flap, or what's called as the bay window technique, where instead of actually punching out a region of the neo-aortic root, actually make a bay window and allow the coronary to come in at a slightly different angle into this medially based J-flap as shown in this picture. Another technique that we've used is what we call the cupola technique. That is, we bring the coronary into the aorta, but instead of directly completing the anastomosis with just coronary tissue, bringing in a so-called aortocoronary flap, either made up of homograft or pericardium or prosthetic material, that allows the coronaries to fall back, if you may, rather than having to be tented up into the neo-aortic root. This is very frequently utilized by us, especially if there is a side-by-side orientation of the aorta and the pulmonary artery, and that is rotating the button. So we'll harvest the button out of the neopulmonary root, mobilize it as best as it'll allow us to, and instead of putting it in the same orientation into the neo-aortic root, it can usually be rotated as little as 30 degrees to allow it to lay in a more natural orientation to prevent kinking, especially if there is a circumflex coming off of the right. Another situation where this is particularly useful is when there's a single coronary artery. So the author of this paper called it the inversion technique, where you take a coronary button with both the coronary orifices from the neopulmonary root, lay it back such that what was the cranial orientation now goes caudally into the neopulmonary root, and subsequently put in a patch of so-called aortocoronary flap in order to make sure that there is no kinking in the two coronary arteries that come from the single orifice. These are all attempts to maintain the native coronary artery and be able to perfuse through them. There are circumstances when the native coronary artery is no longer usable. So we had this patient who was a late presentation to us for a switch operation, had an attempted coronary transfer at a previous operation, and essentially the entire left main was no longer usable. This was an older child, and we were not able to resite the coronary because there was substantial involvement of the anastomotic area. So in this case, we elected to do a bypass. As you can see in the picture, the child had a well-developed internal mammary artery. So we took down the internal mammary artery and put it onto the left main, and the child had, as you can see, postoperative cath showing excellent perfusion, very good function. Child's now 4 years old, doing really well. Sometimes this may not be possible, especially if it's a neonate where the IMA is too friable or not big enough. So that happened to us in this instance, where we were able to turn down the subclavian artery, and so the subclavian as a bypass into the left main, and the child came off pump and has very good heart function. This is an in situ utilization of the subclavian artery. People have described using the subclavian artery as a free graft, where they just take a portion of the subclavian, either do an interposition graft or use it as sort of a flap to bring the coronary up into the neo-aortic root. So these are various ways to try and approach a coronary insufficiency after the arterial switch operation, which is going to be the majority of times when we're unable to wean from cardiopulmonary bypass following arterial switch operation. Sometimes these can be handled just by changing the orientation of the aorta. Like the aortic root orientation by pulling up or so-called pexing of the aorta to get rid of a slight kink in one of the arteries that are coming out. Sometimes the relationship between the reconstructed aorta and the pulmonary artery is the cause of coronary obstruction. The LeCompte is either too tight, or the orientation of the neopulmonary artery is not in the so-called usual position because we started off with an abnormal relationship between the aorta and the pulmonary artery. So there are various ways to reposition this and get out of this situation, and one of those is the judicious use of LeCompte maneuver. We don't believe that the LeCompte should be universally used in all switches, especially in a Taussig Bing orientation. We've tended to less frequently use the LeCompte than not do it. Another option is to do this lateral PA translocation. It could be either to the right or to the left. So you've done the whole reconstruction. Now the PA, neo-PA root, as you put it into the PA, is going to sit on one of the coronaries. What we do is we just patch close the distal PA, make a separate incision far away, and put our new PA into that to keep it away from the coronaries. You can either do an interposition graft or extend the AP window to elongate the pulmonary artery, or rarely have to do a full RV to PA conduit in order to completely resite the entire neopulmonary artery. So those are maneuvers to address coronary insufficiency because of a primary coronary problem. We'll go to the two more rare reasons for not being able to wean from cardiopulmonary bypass. The first is neo-aortic root pathology. So in this case, predominantly it's an aortic valve problem where this is an echocardiogram, a TEE of one of our patients where he had a switch arch VSD done. It was a very difficult VSD to close. Whenever possible, we make a conscious attempt to put the VSD patch away from the aortic annulus so as to not distort the annulus. Possibility didn't exist in this case, and unfortunately, the child has significant aortic insufficiency. It's usually iatrogenic, as it was in this case, usually related to the VSD closure. The primary learning point here, obviously, is to avoid it. Rarely this can come because of stenosis, especially if the original pulmonary valve was bicuspid and we still switched. There are very few strategies we can do to recover from this. Of course, the most advisable one, if it can be done, is aortic valve repair. So if it's just an injury to the leaflet or a clear area where a suture went through, to be able to repair it, patch it. Rarely be able to do a single leaflet Ozaki, and Chris is here. He'll may have something to say about doing that in a neonate, which is often very challenging. Not infrequently, this requires replacing the neo-aortic root. It can be replaced with a homograft, or in that echo that I showed you, we did a Ross procedure at that point. So we switched back. We took the pulmonary root and put it into the neo-aortic root position and used a homograft to reconstruct the RV outflow tract. Very rarely you'll be able to take down the VSD patch and sew it somewhere else. The vast majority of the time, this requires aortic reintervention and makes for a very long day in the operating room. Lastly, neopulmonary root pathology. Again, problems with neopulmonary root reconstruction usually manifest as coronary insufficiency, as we saw in the earlier part of this talk. Rarely, neopulmonary root pathology can present as RVOT obstruction, whereby the right ventricle is just very thick, there is inadequate pulmonary blood flow, the child is cyanotic, and you're not able to come off cardiopulmonary bypass. This can happen because of obstruction in the subvalvar, valvar, or in the reconstructed root, supravalvar region. Far more common with the Taussig-Bing anomaly. So in this study, up to 30% of their patients required RVOT intervention concomitantly at the time of primary complete repair of Taussig-Bing to relieve RVOT obstruction. So in that paper, and also in this European paper from Germany, they've done RVOT resection, where they just look down the neopulmonary root, or when they're closing the VSD from the tricuspid valve, cut out conal muscle from underneath the right ventricle outflow tract. We don't have a lot of experience with that. It's not the kind of anatomic disease process we've seen. For us, this usually requires a right ventriculotomy, coring out any of the obstructing muscle bundles, and usually a patch augmentation either at the infundibular level or sometimes even in a transannular level to ensure that there is no residual RVOT obstruction. Now, frequently in a Taussig-Bing anomaly, as you know, the right coronary artery may run in front of the neopulmonary root, precluding a transannular augmentation. In that case, we've had to use an RV to PA conduit. So in our own experience, about a quarter of patients with Taussig-Bing anomaly have required RV to PA conduit placement to avoid this neopulmonary obstruction and inability to wean from cardiopulmonary bypass. So in summary, inability to wean from cardiopulmonary bypass after an arterial switch operation until proven otherwise is coronary insufficiency. There should be a high index of suspicion to diagnose it early in the operating room and correct it there and not postpone it for another interventional or second procedure. Familiarity to approach variations in the coronary anatomy or different techniques to reconstruct the coronary will allow you to recover from a situation where it's primarily coronary insufficiency. Rarely, intervention in the LV and RV outflow tracts are required in order to safely wean from cardiopulmonary bypass. Thank you for the opportunity, and I'll take some questions.
Thanks, Ram. That was an excellent talk. I think particularly highlighting the Taussig-Bing patients, that can be very challenging both for VSD closure and also addressing the RV outflow tract. We're going to open up the floor with some questions.
Yeah, Ron, Bill Douglas, that was great. It was resonating with me because I've managed to collect a few patients with the switches and with really difficult VSDs to close, especially if there's a little bit of anterior malalignment in the conal septum. And I've gone quickly to closing those through a right ventriculotomy. I mean, it seems like it's heresy to close a VSD through the ventricle, but I've had difficult time trying to see them through the atrium, and that would just be my experience to have a low threshold for making a ventriculotomy to close some of these difficult VSDs in patients with detransposition.
Yeah, we agree. And we do our tetralogies through a ventriculotomy anyway. So for us, making a ventriculotomy to close the VSD is not so unusual at our center anyway. So you agree completely. Dave?
I'm sorry if I missed it, but did you talk about external compression of the coronary button in the setting, not in the setting of a Lecomte, but when a Lecomte is not used? So I'll give you an example of what I'm talking about. So Tausig Bing, side-by-side great vessels, and relationship of the great arteries, you choose not to do a Lecomte. We had a case like this recently, came off, echo looked just like that. And if you pulled that now slightly under tension LPA away from the back of the neo-aortic reconstruction, instantaneously sinus rhythm and LV starts moving. So what had happened was because of not a Lecomte, now behind the neo-aorta, the LPA is compressing that left coronary button. And we resolved that by an interposition graft of Gore-Tex to extend the PA confluence further posteriorly and away from that left coronary button, and that worked out well. And I would say that in that anatomic setting, that's not the first time we've had to do that. So an extension of the MPA with an interposition graft can often relieve the coronary compression, and it's a relatively easy get, even just do it on a beating heart and like that. So that.
Agree. That was there, yes. Extending the main PA to take it off of the coronary externally is, yeah.
Ram, what goes through your mind when the heart looks like that and you're trying to figure out whether it's the right coronary with the circumflex or the left? So
the first thing that goes in my mind is, uh-oh.
Yeah, but what are the things which button are you going to redo?
So we will, at that point, we'll rearrest the heart, open the aorta, look in, and then make a decision by probing. Often, when we go back on, you could look externally and see which coronary is more plump, which is not. Sometimes you'll have regional wall motion abnormality. And like Dave was mentioning, arrhythmia, sinus rhythm tends to be more on the right side. So many times the judgment can be made externally, but we'd also probe both coronaries from inside.
Yeah, I think physical manipulation, of the reconstruction and can often, kind of tell you, if you can figure it out by simply moving things around and seeing what sort of manipulation results in improvement. And that'll usually tip you off as to where the problem is.
Ram, are you assessing the coronary arteries by echo when you come off? I know there's a mixed bag here where some echocardiographers are particularly attentive to flow acceleration in the coronaries, and others tend not to assess the coronaries by echo.
Yeah, our echocardiographers usually, make it a point to look at coronary perfusion. But of course, they can only see the proximal few millimeters, but they will mention it to us in the operating room, whether there is or is not flow and acceleration.
And so what is your indication based on echo parameters to revise a coronary?
So we've never found ourselves in a situation where we're having good function, we're coming off, and the echocardiographer picks up on the gradient. Usually we've known it before that.
I'm curious in the audience, how many people routinely use coronary probes after the coronary transfer? Another little trick I've used that I found helpful is that when you're dearing your aorta, when you're completing the aortic anastomosis, if you just run a little cardioplegia into the root and see the coronaries plumping up, and that's a nice little trick to know that you're probably okay.
Yeah, we do that routinely. So in all our cases, once the coronary transfer is done and we put the aorta back together, we de-air the aorta with a needle and then give them a dose of cardioplegia to make sure, because we do all our neopulmonary root reconstruction on cross-clamp, so that gives you another extended period of time with a cardiac protection.
And you can also see if you've got any leaking at, posteriorly where you can't see after the Lecomte if you do the Lecomte. Hani?
Quick comment. My best guide of what the translocation is the LA line. I still use them in every transposition. I keep them, and these are, I don't care about what the echo shows. I don't care about anything. If the LA pressure is low, you've done a good translocation, and that's the end of story. Regarding the translocation of the main pulmonary artery to the lateral, you've mentioned that you could go it very far away from the original main pulmonary artery. I don't think you can, because you're going to get into the PA, and it's a different angle. You're going to get into that branch stenosis, whether you're taking it to right, left. Usually, you just need half of the MPA closed and half of it to the other side, just enough to get enough tension removed, just like what David was saying, to get the coronary.
Chris?
I just want to make a plug for using echocardiography in the operating room to assess the quality of your coronary anastomoses. I think if you're relying on looking at the vessel externally or saying, well, the function is good, therefore the coronary is okay, or the LA pressure is low, therefore the coronary is okay, is less sensitive to potential imperfections in a repair than we ought to be. It's not very hard to make coronary flow velocities go down, often just picking away at some adventitia, a slight revision here or there, and you can make things more perfect. Does it improve mortality? Well, it's hard to say because, of course, we have very low mortality for switches anyway. But if you can make things more perfect by assessing them in the operating room and fixing them, why would we not?
Chris?
Yeah, I agree with Chris. We do epicardial echocardiogram specifically looking at the ostium of the coronary regardless of the LA pressure and regardless of the rhythm. So I think that's critically important, and to look at the adventitia. Secondarily, intraoperative angiogram, that's an option. We'll occasionally do that if there's any question. And another tool is the SPY system, which is actually a great tool for coronaries that we've been using recently to identify coronary lesions. I can't say we specifically have done it a lot on detransposition, looking for patency of ostium, but it's a good tool.
Chris, before you go, can you explain the SPY system to the rest of the folks who might not?
Yeah, actually,
not familiar with that?
Eric Fines from our group has a publication that's coming out soon to describe our experience in it. But it's essentially you can fill the root with dye and use a probe on top of the heart, and it will light up the coronaries in a very quick and efficient way.
Just to add to that, we've used that too, but the FDA indication is only for patients as young as a month. 1 month is a cutoff. So in patients with redos, pulmonary atresia, planning a conduit, it is helpful, but there is that lower threshold of 1 month that we've seen.
Thanks, Ram, and I'd like to thank all of the speakers for, first of all, showing up today, and thanks again for Glenn filling in at the last minute. And thank you for all of the questions and comments. Great session.